The next ICMR is a report from the Malawi ICMR by Dr. Don Mathanga from Malawi. Don, 30 minutes.
30 minutes, that's a lot. Okay. Yeah. So, good morning. My name is Don Mathanga, and I'll be presenting on behalf of the Malawi ICMR. Just to acknowledge that the group that made the Malawi ICMR are actually what you can see in front of there, the logos in front of there. This is an ICMR that was awarded to Michigan State University together with the University of Malawi. So I'm here actually representing Professor Terry Taylor, who is the PI on this ICMR. But the other teams actually included University of Maryland, University of Michigan, Harvard University, and the Einstein School of Medicine. So I think I will do this a little bit differently in a sense that the results that I'm going to present are what we call the key results, which actually inform what we are going to be doing in the next few years in terms of trying to understand malaria in Malawi. So let me just, first of all, maybe kind of describe what Malawi is for those of you that may not know. This is a small country in sub-Saharan Africa, actually just close to Zambia, but with Tanzania on the north and then Mozambique on the southern and the western side as well. The health indicators there are quite bad, 66 for infant mortality rate and 112 for under 5 mortality rate. It's a very poor country with a GDP of about 226. Now, malaria is such a big problem in Malawi. Actually, the whole country, there is malaria transmission going on. And actually, in 2014, we had about 4 million cases of malaria, which translated to about 21% of the OPD visits. If you look at in the under 5, then you are looking at 46 visits out of every 100 were to do with malaria. Now, because of the high burden of malaria in Malawi, the Malawi government, as early as 2000, made a decision actually to scale up all the interventions within the country. So you can see from this slide that if you look at 2000, and if we take bed nets as one of the interventions, you have something like 4% coverage in terms of bed nets. But by 2014, we had gone all the way to 80% household coverage of bed nets. Again, use of this intervention, ITN use in under 5 children dramatically has increased to about 66% in the under 5 children and about 60% in pregnant women. Again, the Malawi government also scaled up access to treatment, introducing ACTs in 2007 and RDTs in 2013 as part of the case management protocol. We are way behind in terms of prompt access, with only about 28% accessing treatment at national level. And when you look at SP use in pregnant women, 2 doses or more, this is based on a 2014 DHS, about 55% only be accessing SP. Now, I actually titled this Stubborn Nature of Malaria in Malawi for a specific reason. Because if you look at this slide, and when you think about the interventions that have been scaled up across the country, you really don't see much of a dent in terms of malaria. So this is really based on some modeling work that was done, looking at a number of surveys that have been carried out in children between 2 years of age and 10. And you can see that, you can see that there is a lot of malaria across the country in 2000 with the high prevalence rates along the lake and the Rift Valley, the Shire River Rift Valley area, which is in the southern region there. Come 2012, you still see almost the same pattern, despite this high scale-up of interventions. Actually, based on that modeling work, it shows that actually the people living in hyper-endemic areas has actually increased by 27%. So not much change, really, in terms of parasite prevalence, despite the intensive scale-up of interventions across the whole country. Now, several works as well have been done trying to look at, to try and validate that, where people have shown that instead of maybe decreasing malaria admissions, as has been the case in other countries around the sub-Sahara, around Malawi, in actual fact, in Malawi, malaria admissions have been increasing rather than decreasing. We have actually shown no decline as well in terms of severe disease. So in the midst of all this, we got our ICEMA. Basically, the ICEMA was there basically to create some kind of capacity within Malawi to establish some scientific basic for designing, implementing, and evaluating malaria control and prevention strategies. So we had three main projects, mainly all of them really to try and understand malaria within Malawi. One of those was based in the urban center, in the urban setting, which is Blantyre City, basically to look at what are the factors that are associated with malaria within this setup. And then the other was a facility-based study that was basically doing surveillance across three sites. And these sites, Blantyre City, which is a low transmission area, Cholo District, about 50 kilometers east of Blantyre, which is an area in the Shire Highlands area, where you have a medium transmission area. And then we had Chikwawa District, which is in the lower bit of Malawi, south of Blantyre, again, with high transmission area. So all of them within the 50-kilometer range. So the urban malaria study was based in the Blantyre City, but the facility-based was being done in all the three sites in trying to really establish what is the burden of malaria within these sites. Then we had cross-sectional studies as well that were being done across all these three sites, just basically to understand the burden at community level and all that. So basically, these are some of the objectives of this. Key to this was really basically to establish some basic molecular and genomics capabilities within Malawi, because although that is being taken for granted in many countries, in Malawi we didn't have that kind of capability, so the ICEMA supported in us trying to establish this. So what I'll do is just to really walk through some of the brief results that we've gotten with this ICEMA. I will not go study after study. Instead, maybe I'll just pick up the key ones and show how that maybe is influencing some of the thinking that we have in terms of going forward, either with ICEMA or with other funding that in terms of trying to answer questions that are pertinent in this study site. So this slide basically is just showing you the three sites where we were working: Chikwawa District, Cholo, and Ndirande. Ndirande is a health center within Blantyre City. So basically there we were interested in looking at the people that were coming to the facility and just establishing the burden of disease within those facilities. And what you see is that for Chikwawa, which we already designated as a high transmission area, almost 30% of all the OPD cases were actually people that had malaria parasites by RDT. If you go to Cholo, almost 20%. If you go to Ndirande again, even though it's in the urban setup, you're seeing about 20% as well of malaria. But critical for us with this was the finding that basically if you look at that, you have quite a high burden amongst children that are 5 to 15 years of age. And those of you that are familiar with the with the malaria literature, I think the emphasis has always been in under 5 children. That's where we have targeted the interventions, completely actually neglecting this other group, which is 5 to 15 years. We were able to show through this surveillance that you have quite a huge burden of malaria within this age group, actually signifying the shift that people have been talking about for quite some time. This is just a repeat of that in 2013. Again, the pattern is the same, not changing at all. So this is one of our key findings that we think we would want to look at critically as we go forward in terms of malaria control in Malawi. One other thing that we were interested in is just to look at the case fatality rates and to try and understand how much mortality is associated with malaria. Again, Chikwawa, high transmission rural area, Cholo, medium transmission urban setup, and then a central hospital here in Blantyre where all the admissions for malaria are being done. And what you can see there is that still there is high mortality rates associated with malaria in this setup, especially in the rural areas. Now, we're not so sure why is that, what is the case there. Maybe it's because services are being are being taken rather late, as you saw that prompt access is just at about 28%, or maybe because the protocols, the case management protocols, especially for severe malaria, are not being adhered to in the rural facilities. So a lot of death actually associated with malaria within that setup. Now we go into the community. This is just to look at parasite prevalence. Again, Chikwawa tops it all there. High transmission, almost 30% of children during the rainy season have got malaria, and about 20% during the dry season. So across all the sites, what you see is that there is definitely a lot of malaria within the setup where we are working in. This slide here just again points to some of the things that we would like to do going forward. Basically, what we have there is just looking at the surveys that have been done across the 3 sites. These have been surveys that have been done repeatedly over a period of time. And we kind of tried to look at the people that, the proportion of people that were parasitemic but did not have any symptoms of malaria. We think this is critical for us because we believe that there is a huge reservoir out there, and actually this is what it is pointing to. Almost 60% of children 6 to 15 months old would be running around actually with malaria parasites with no symptoms. So potential for transmission quite high within that group. But if you look again in the 5 to 15 years, critical for us, that is, they are more likely actually to have malaria parasites and be able maybe to transmit this compared to those within the 6 to 59 months. Again, if you look at those that are 16 years or older, the pattern is the same. So lots of asymptomatic malaria out there, especially asymptomatic infections with malaria. Again, as I pointed out, we had a cross-sectional surveys that were being done across these 3 sites, basically during the rainy and during the dry season. One of the key things that have come out of that is that you see a lot of heterogeneity, even in districts where you expect to see high transmission. Let's take Chikwawa, for example. These are repeated surveys in the same areas. Basically, what it shows is that you have areas that repeatedly have high parasite prevalence and areas that have repeatedly low prevalence of malaria. If you go to Cholo, the same thing. You go to Blantyre, which is the urban site that we had, you see as well the same kind of pattern. This all raises the issue that environmental issues might be key as well in malaria control, something that maybe we don't pay particular attention to in this particular setup. Again, based on work that we have been doing as well in Malawi, together with some collaborators that have worked with us on this ISMR, but mainly this is with funding from CDC, it was just trying to track the needs. since we don't see much of an impact, what is happening to the nets when we put them in the community? And what we have been able to show is that once you place nets within the community, almost 30% of those are going to be lost by 6 months, okay? And then if you look at that, by 18 months, almost 50% have been lost, and by 36 months, you've lost almost 75% of the nets. Mainly, you are losing these nets actually to wear and tear, and sometimes as well, you're losing them because they're being used elsewhere outside the house. Either they've been given to a child who's going to school, or people that are going to sleep in the field, tending to their plants and stuff like that. Or some of them are just being misused, plainly being misused. So this is a critical finding for us, the bed and attrition rate within southern Malawi, since it determines whether the interventions actually are going to be working or not. This bit is just showing the low intervention utilization in some groups. Again, here I kind of focus on the children 5 to 59 months, 5 to 15 years of age. If you look at that, they are the worst in terms of sleeping under bed nets. Yet we are seeing a lot of high burden of disease within this group. They are the ones that as well have got a lot of parasites which are asymptomatic. Okay, so they hardly use bed nets. When they have parasites, when they have got symptoms, they do not seek care as well as compared to the other groups. So they are the least in terms of seeking care. And when they seek care, they are basically seeking care in shops rather than maybe going to the formal health facility. So a big problem as well that we have identified under the ICMR funding. Insecticide resistance. Again, working with the CDC, who have been a collaborating group on this. Basically, what we've been able to show is that there is widespread, actually, insecticide resistance within the area where we were doing some of these studies. These are some of the nets that are available, and taking those nets and exposing them to mosquitoes, you can see on the y-axis the mortality rates there. You don't go as much as 40%. Actually, Olicet is the one, Olicet net is the net that the Malawi government is actually providing at national level. You can see that it's maybe the best you can go with that is just about 5% in terms of mortality. So insecticide resistance, a huge problem. Even for ITNs that have got synergists, if you look at Olicet Plus there and Permanent 3.0, all these have got synergists, but you've got problems with those. The only way that you're going to get some kind of high mortality is when you expose the top panel, which has got a high concentration of insecticide. Again, with colleagues, we've been able to show through this ICMR funding and the supportive funding as well from the CDC about the changing behavior of mosquitoes within this setup. Using human landing catches, we've shown that traditionally we have always believed that mosquitoes are going to be biting a lot around 11, maybe up to 3 a.m. in the morning, but actually they are creating a window for themselves to bite, because now they can go as far as 6 a.m. in the morning. We've been able to show this within the setup where we've been working. And by 5 o'clock, most people in Malawi will actually be up and about, going to their fields. So mosquitoes out there and capable of doing a lot of biting and all that. So where does this lead us to? Because if you look at most of the countries within the region, yes, Zambia might be modest and say the decline maybe is due to weather, but if you look at even other places in Zambia, which look more or less like Malawi, the pattern of malaria infection and the pattern is completely different. We seem to have this kind of intransigent malaria in Malawi that despite the fact that we've poured in a lot of resources, we still are not seeing much of a dent. If you look at Tanzania, they are reporting some good things there in terms of trying to bring down malaria as well. If I go further down, look at Zimbabwe, Swaziland, and others, they are all on the verge of going towards elimination. Malawi actually stands out despite all these interventions that are going through. So one of the things that we are thinking in terms of going forward is just trying to really understand what is going on. Why do insecticide-treated bed nets seem not to provide this, the protection that is needed so much in terms of preventing malaria? A lot of things actually that we are hypothesizing for that, either because the bed nets are not there in the community, you kind of try and you lose them as you go, as you go along, or maybe just people's behavior could be one of the things that is taking place within that setup, which leads to actually bed nets not working very well. And just looking at this whole issue about asymptomatic submicroscopically infectious people and how they contribute to transmission, we are showing a lot that children that are between 5 and 15 years of age, lots of malaria within them, and most of them without any symptoms, and we know the interventions are not actually reaching out to them. How does that impact actually on malaria? These are the questions that we would like to look at as we go forward. We just want to look at this phenomenon about insecticide resistance, because we're seeing quite a lot of that, not only in Malawi, but even in the whole of sub-Saharan Africa. So what is the impact of that? I know most of the studies that have been done have looked at entomological indicators, entomological outcomes, but we would just want to see how we can, how insecticide resistance actually affect morbidity and mortality, for example, because we don't think that there have been any studies that have looked at that. And even looking at the behavior of mosquitoes themselves, what is the impact of that late biting that is taking place in terms of morbidity and mortality across the country. We also want to look at the environmental factors. What we are seeing is that bed nets are not working. Is it because there are just too many mosquitoes out there that even if you place bed nets or IRIs out there, it's not going to work because people are going to come across these mosquitoes anyway. So looking at climate, geography, and vegetation and how that actually is impacting on malaria. And then how all these factors actually interact with the socioeconomic factors within the setup. So this is what we would want to do in future at population level. But we also want to look at things even at individual level because I think this is critical for us. We have seen a lot of asymptomatic malaria that is out there. We want to understand why certain children actually will move from that asymptomatic malaria to uncomplicated level of malaria, and why so few children are going to move from there to the cerebral malaria bit. What factors combine to support prolonged persistent asymptomatic parasitemia, which we suspect is actually the case within Malawi? What changes when an individual becomes symptomatic? And what are the various host and parasite factors of interest, and how these differ between those that are asymptomatic parasitemia and those with a life-threatening malaria. So in a nutshell, this is the presentation that I wanted to share with you, highlighting that we are not really seeing much change in terms of malaria control in Malawi compared to the other countries within the region. There is still a lot of work that needs to be done in order for us to understand what is going on in this island within the region where no change is happening, and how maybe we can address some of the questions that would help in terms of trying to understand this. Finally, I would like to thank the NIH for the support that they've given to the Malawi ICMR for us to be able to do this work, and to thank the organizers of the meeting as well. Thank you.
You might be interested to know that I was the medical entomology in Malawi in the 1960s.
All right.
Yes.
Pleasure to meet you.
So I worked.
Thank you.
I'm here. Yeah. So I have a question on your asymptomatic and high parasitemic children, or the individuals in general. How long they are asymptomatic, and Did you look at the gametocytemia of those asymptomatic and parasitemic individuals?
Actually, how long they are asymptomatic, because this is a cross-sectional study, we don't know how long they were. But we are actually planning to look at this, because some of the things that we're planning is really to do some kind of longitudinal studies, where in essence sometimes we identify people that maybe they've got parasites but are not due for treatment based on the national guidelines, and then be able maybe to follow them over a period of time just to see the persistence of this asymptomatic parasitemia. We think that by understanding that, we'll be able to know the reservoir that is out there in terms of infecting other people within the community. In terms of gametocytemia, actually, there is work that is currently going on. It's not part of this. It's still funded by NIH, but using the same platform. But that work is still going on, and I didn't have any slide to present on this.
Thank you.
Good morning. Good morning. Thank you for your presentation. I really enjoyed it. And I just want to share a comment or experience. I've lived and worked for many years in Nigeria. I know there's a presentation on West Africa coming up. But in terms of the use of the nets, talking from experience, personal experience, as well as other people's experience back in Nigeria, I think the point you made about behavior is very important in terms of the effectiveness of nets. I don't know what the weather is in Malawi, but in Nigeria it's very hot. Most of the time, even during rainy season, it can be very hot, and people will not sleep under nets. It's like you feel like you're suffocating under the net. So I don't know, it hasn't been mentioned yet in terms of all this, so far, but maybe it will come up later on. But I think behavior is key. And also, also happy about the fact that you mentioned the observation that mosquitoes bite at different hours than when we think they actually bite. So many times, at least in Nigeria, mosquitoes bite before you go to bed. So the nets are not going to catch those mosquitoes at that time. So mosquitoes bite a lot before people actually go to sleep, both before and after. So I just wanted to share that. Thank you.
Thank you. Thank you so much for that. I think this is one of the things that we are particularly interested in, the behavior of individuals in terms of whether they are using bed nets or not. It's something that I think has been documented in many places, even in Malawi as well. It's hot out there, especially along the lake shore and along the Rift Valley area. So potential for people not using bed nets, or maybe starting to use them rather late in the evening, or maybe even getting out of the bed nets themselves early on when the mosquitoes are still biting. That's a critical thing that we think would actually have an impact. So this whole raises the whole question about even bed nets, whether this as an intervention is something that we can totally just rely on. Because, for example, Malawi, this is the only intervention that we're using. IRS is not in use because it's expensive. Can we just totally rely on bed nets really to control malaria? Raises a lot of questions. Thank you.
Well, thank you very much indeed.